Hi, this is Brian Kim. I want to share with you this case of a dislocated IOL. This patient was actually referred by her primary care doctor, so obviously he wasn't aware of the actual nature of the vision problem in this patient. This patient's actually also from another country, just came and immigrated to the US about 2 months prior. And because of the language barrier, it's really hard to get a good history as far as what exactly happened. She's fairly young, and it sounds like maybe she has high myopia because she does have geographic macular atrophy in both eyes, and she is fairly young as well. She did have cataract surgery in both eyes, and her right eye is doing fine, but the left eye, she just noticed that the vision's been very blurry for quite some time. We don't know how long it's been this way, but what is very interesting is not only does she have a dislocated single-piece acrylic lens in the ciliary sulcus on the left side, but it's also on the right side. It's just not quite dislocated on the right eye. But you'll see in a moment the dislocation of this lens. And this case is really to illustrate the fact that secondary IOL surgery or dislocated lens surgery is truly like a box of chocolates in the sense that you really have no idea what you're getting yourself into. So it's very important to have an algorithm in front of you and a decision-making tree that you can picture in your mind as far as what you can do and what you can't do as you examine the patient, and while you're actually in surgery doing the case, figuring out how to best execute the surgery, and making the appropriate steps and planning is so important when you're dealing with these challenging cases. So you can see this is the eye. You can see that there is a dislocated lens. It's a single piece acrylic lens in the ciliary sulcus. So if you can see right here, this is the outline of the lens right here. And the lens is not a lens that I'm familiar with in the United States, but it's clearly in the sulcus. And so the first thing I'm going to do is prepare for Yamane. So you want to dry the surface of the eye, and then I like to mark and ink the tip of a 27 gauge cannula. I mark it on the right side and then the left side. And these are the fixed calipers by Epsilon. You want to dry the surface first, and I'm going to indent the sclera 2.5 millimeters posterior to that mark, and then 2 millimeters adjacent. And the fixed caliper just makes it so much easier versus an adjustable caliper. Dry off the surface with a wax cell sponge, and then directly ink those indentations. Do the same thing on the left side, indenting the sclera 2.5 millimeters posterior to that mark, and then 2 millimeters adjacent, making sure I dry the surface first, and then apply the ink. Making a paracentesis incision on the right side, and then the left side, which will help me for the explantation of this lens. And this is the incision for the externalization of the leading haptic if I have to do it. And this is the incision for my AC maintainer. Again, all the steps thus far is in preparation for the Yamane technique, because that is really my get out of jail card. Injecting some intracameral epinephrine, and as I do this, you can see the vitreous moving underneath the lens, but you can also see the lens is wobbling quite a bit within the ciliary sulcus. And so we got to get this lens out. I'm injecting some dispersive viscoelastic. First, inside the little hole, there's a posterior capsule defect. I'm pushing the viscoelastic through the hole to make sure that vitreous doesn't want to come forward. And then I'm filling the anterior chamber and coating the corneal endothelium. Using the cannula to control the eye, this is my 3 millimeter diamond blade. And I want to make sure that that incision is at right angles to the marks that I made. Because if I know that the way I planned the surgery doesn't go the way I want to, I can always fall back on the Yamane technique. These are the micro forceps. Grabbing it with the two-handed technique, I lift the lens up, positioning it in such a way that I'm going to plan on cutting the lens. Once I have a firm grip with the left hand with the serrated IOL holders, I switch the right hand to the IOL scissors. And the way the lens cuts, this is clearly an acrylic lens. You see I'm grabbing and re-grabbing because I want to make sure I get to the other side of the lens and cut it. Right here, again, it's a little bit of a big lens, and I'm just being mindful of the cornea. I don't want to touch the cornea. I don't want the proximal lens piece to hit the cornea, so I'm very mindful here. I'm trying to make sure it stays nice and flat, pushing that forceps down away from the cornea while trying to make sure I'm able to fully bisect the lens in half. So go ahead and bisect it. Take the scissor out, switch to another micro forceps, At first here I decided to pull it out, but because of the way the haptic is turned, I don't want it to hook into the incision and scrape the cornea. So I'm going to rotate the lens 180 degrees, grabbing the cut edge with the right side forceps. As I'm pulling out, I'm losing a little bit of grip on the lens, and now the lens is kind of caught up into this subincisional area. So I decided to come out, push some more viscoelastic in, and then I just reset. So there's no sense to struggle. Just stop, let go, fill the eye with more viscoelastic, and then you can go ahead and try to go after it again. Because I was able to inflate the anterior chamber and push the lens away from me, I was able to grab the edge, the cut edge, and then gently pull it out. And because I rotated 180 degrees, as I pull the optic out, the haptic collapses on itself. Go after the other piece now, grabbing the haptic so I can pull it away from my incision, and then grabbing part of the optic there with the left hand forceps, and then kind of handshaking my way all the way across, inching my way across to the other side, grabbing that proximal cut edge of the optic, and then as I pull it out, I use the left side forceps to shield the cornea, to protect the corneal endothelium. You can see the capsulorhexis edge on the left side right here, but you can see that it's discontinuous. There's no continuous curvilinear capsulorhexis. That's why I think the surgeon put the lens in the sulcus. And now you see an eccentric posterior capsule defect right there. So all of these things I'm thinking to myself, is the bag salvageable? Can I keep the bag? Can I keep the capsule? I go ahead and put my AC cannula in, and then through the posterior capsule defect, I go in with the vitrector and I start to do some vitrectomy. You can see there's quite a bit of vitreous. And as I'm doing the vitrectomy, I'm thinking to myself, how am I going to put a secondary lens in this case? Again, the anterior capsule is fused to the posterior capsule. Clearly, the anterior capsule is discontinuous. Clearly, the surgeon wasn't comfortable putting the lens in the bag. But is there a posterior propagation of the capsule? I don't see that. It looks like it's an intact capsule. The zonules look pretty strong. I don't see the bag flopping around. So I'm trying to assess to myself, is there enough zonular integrity and capsule integrity to be able to hold the lens? Or do I have to abandon all the things that I just said, eat the capsular bag up, eat the zonules up, and then do a Yamane technique? In my opinion, if you can keep the bag, you want to keep the bag. So as I'm doing the vitrectomy, I decide to widen the posterior capsule defect with the vitrector. And so I'm trying to use the vitrector to eat the edge of the capsule, of the posterior capsule. And I'm thinking to myself, is this the best way to do this? Because I'll be creating tiny little munch marks, little cut marks from the vitrector. Maybe I can do a manual posterior capsulorhexis. And so that's when I stop. I use the micro scissors to cut a small cut within the posterior capsule. And then using my microrhexis forceps, I'm going to try to make a posterior capsulorhexis on this patient who has a dislocated IOL with a posterior capsule defect. So again, a little bit different. Sometimes you have to think outside the box and think a little bit creatively when you're doing these cases. And so as I tried to make the rhexis, you can see the flap flipped over on itself. So it's okay, just take your time. You want to make sure you grab it properly. So I grab it here, and now I'm actually doing the rhexis, and it's going around. And what's interesting is there's a lot of cortical material there, and so it's kind of almost tethering the capsule as I'm trying to pull it. But it's very important to realize that those cortical remnants are not where the rhexis is. They're just kind of like little strands that are blocking the way. And when I finish off the rhexis here, it looks like the rhexis is really small, but it's actually pretty big. It's about right there, about that diameter. And so it's fairly well centered. I was able to complete it all the way. So I feel really good about the posterior capsulorhexis that we made. And it's small enough that I know that I can optic capture the lens. The real question is it going to be stable, or is the bag just going to completely collapse on me? So I go ahead and inject some cohesive viscoelastic into the cartridge. And this is a Sensar lens. And why am I using the Sensar lens? Because I know that if the case goes sideways, I can use this lens to do the Yamane technique. Place the cartridge into the injector. You want to make sure the trailing haptic is sticking out over the side. I advance the plunger and it goes right in. And this is the way you want to load the lens. And with these cases, I always load my own lenses because you don't want anything bad to happen to the haptics. Placing the injector into the incision, Bevel down, turning the bevel to the left, advancing the leading haptic into the ciliary sulcus, pronating my wrist and allowing the optic to come out nice and flat. You can see how nice and slowly the sensor optic opens. And then I'm going to dial the trailing haptic into the sulcus. Now the lens is completely in the sulcus. It's nice and free. And then I'm going to tuck each edge. I'm tucking the distal side and then the proximal side in an optic capture configuration, which is essentially a buttonhole technique. Now the lens is buttonholed within the posterior capsulorhexis. Place the AC infusion cannula as well as the vitrector. Start to do some vitrectomy, essentially removing the viscoelastic from the anterior chamber. Switching sides, and I'm using the AC cannula, the pressure of the AC infusion cannula, to liberate and loosen up some of that OVD that's in the angle. So you can see I'm kind of moving that cannula side to side and making sure I'm trying to clear any OVD that might be stuck in the angle, and using the vitrector to aspirate and remove the OVD. As I take out the AC infusion cannula, I push BSS with the cannula to maintain the chamber stability, and then I quickly hydrate my incisions. So you can see here very nicely, now I have a well-centered lens through a posterior capsulorhexis and an optic capture configuration with the sensor lens in the ciliary sulcus with the optic capture. You can see the nice oval appearance of the capsule. Go ahead and place a 10-0 nylon suture over my main incision, and I always like to do this in these complicated cases. And then I'll hydrate my incisions, and this is the end of the case. So this is a patient, again, high myopia, out of the country, a little bit of a language barrier. Not quite sure what happened with this patient, but clearly there was a rhexis runout during their cataract surgery. This patient's fairly young. Maybe it was one of those capsules that tended to run out, very elastic capsules when she was, again, a young patient. She had a rhexis run out. The surgeon took the lens out, didn't feel comfortable putting the lens in the bag, and then put in this single piece acrylic lens into the sulcus. This patient ended up having tilting of the lens, and the tilting of the lens could be attributed to this patient being a high myope, because this patient does have macular degeneration, presumably myopic macular degeneration. This patient has a high axial length as well. And because of that, big anterior chamber and this single piece acrylic lens dislocated in the sulcus. So again, not really surprising scenario, but the lens had to come out. You saw I bisected the lens in half. And then as I'm doing vitrectomy, I'm trying to figure out what to do. But remember, I did all the plans for the Yamane. I made my marks, I made my incisions, the ink marks, all this stuff. You might say, man, that was a waste of time. But no, it wasn't a waste of time. It was good preparation. Because I know once I get the case started, if I decided to change my mind and then do Yamane later, and I didn't make the requisite steps, and I didn't mark and make my incisions, I would put myself in a much worse situation. But you can see now, I was able to cut the posterior capsule, perform a posterior capsulorhexis, and then placing the sensor lens into the sulcus, optic capturing it now, and you can see there's a perfect ovalization of the capsule in that buttonhole configuration with the haptics in the sulcus and the optic underneath and buttonholed within the posterior capsulorhexis. And this patient ended up doing very well. The lens is nice and stable. And now she says to me, when are you going to do the other eye? So at any rate, that's another case for another day. And I may post that case in a future video. So I hope this was helpful to you. And I thank you for your attention.